Do we check the FDA guidelines? Do we Google or do we check GPT? Do we read the drug leaflet or do we warn the mother that this medication is not safe, or do we ask her to stop immediately? Now, what is our common routine practice? I'm going to highlight the principles in my talk. I'm going to talk about the principles of prescribing. I'm going to demonstrate 10 clinical needs of real patients that I've managed. I'm going to discuss essential pregnancy pharmacokinetics, the importance after today that we as clinicians must always balance the benefit against the risk, the importance of making an informed shared decision, and finally, if you're not sure, the importance of asking the right expert. And these are going to be the highlights of my talk. In the gist, in a nutshell, ladies and gentlemen, the principles of prescribing in pregnancy, the most important principle, we should treat every pregnant mother the same, like a non-pregnant mother. And that brings to the strong point of equity for pregnant and breastfeeding mothers. The second important principle, it should not always be the risk, but it should be the balance between the benefit and the risk. If that one particular medication or intervention is going to save the mother's life, I think we should not deny that mother that important medication. And I believe these two important principles are extremely important when it comes to prescribing in pregnancy. So I'm going to tailor-make my talk based on these 10 clinical needs. A 27-year-old mother had isoretinoid exposure pre-conception. How do we counsel her? We often talk about aspirin and we talk about doses, but I'm going to highlight the importance of weight-based dosing in pregnancy. Should it be the current weight, the booking weight, or should we treat all the pregnant mothers the same? We often talk about the essential first trimester. When do we ask the mother to stop important medications, pre-conception, early in the pregnancy, or when is the ideal time? Sometimes there's a dose-related effect to the fetus. One good example is sodium valproate. One good example is carbimazole that I'm going to highlight. I'm going to highlight the controversies about anticoagulation in pregnancy, especially warfarin. I'm going to highlight the importance of choosing the right antibiotics because although it is important to treat the mother, there may be some concerns with regards to antibiotic usage in pregnancy. Often we talk about mother, but what about the father who takes some medications? I'm going to highlight the importance of checking the father's medications, especially sodium valproate. The important concept of placenta and the gender also as an issue. And how do we counsel if we are really not sure about the safety and the implications of the medications? And finally, I'm going to highlight the importance of checking for levels during pregnancy, especially for low molecular weight, especially for lamotrigine, and certain medications like tacrolimus. And this is going to be the outline of my talk. So ladies and gentlemen, how do we approach? Principle number one, I think we should stop quoting FDA just like that. FDA classification is a classification based on risk. But as clinicians, I think we should make that important decision. It should be the balance between the benefit against the risk. The most important principle, if that medication is important, it is essential, if it's benefit, I think we should not be withheld. The most important question we should ask ourselves, what is the benefit of treatment? Is there any documented studies that is harmful in humans, or was it just animal studies? When it comes to medications, it's important to assess the dose, the route, oral or transdermal, and some risk is associated with doses. But as obstetricians, ladies and gentlemen, it's also important to know at which phase of fetal development. Certain phases are less teratogenic. Certain phases follow the principles of all or none. So it's important to know the exact phase. I think we should appreciate placental and breastfeeding physiology that I'm going to highlight after today. We should also appreciate that a pregnant mother needs more medications because of the pregnancy adaptations, not less medications. But of course, ladies and gentlemen, often it is not we who know everything. It is sometimes okay to check, not to Google, but to ask the right expert, the maternal medicine expert, and finally, to make a shared decision-making by informing the patient. But it is important to be responsible in our prescribing, hopefully after today. So principle number 1, ladies and gentlemen, I think we need an evidence-based prescribing. Question number 1, ask what is the benefit, not just the risk to the fetus. We should not be fetal-centric, but we should holistically treat the mother. Ask what is the benefit of treatment. Now let's take a look at FDA. Magnesium sulfate is actually FDA category D. Although we do know that magnesium sulfate is extremely important to prevent eclampsia, for fetal neurological maturity, it should be given for pregnancies before 32 weeks. It is an important medication that is given for preterm fetuses. It is actually category D. But I think as clinicians, we can appreciate the importance of magnesium sulfate in pregnancy. So instead of following blindly FDA, it should be a guide. It is about risk, but as doctors, we should often make the decision between benefit against the risk. And what is the long-term use of magnesium sulfate? If the mother has got a prolonged exposure to magnesium sulfate, that has been shown to be associated with fetal osteopenia, fetal skeletal abnormalities. But these studies were given for babies that were tocolized using magnesium sulfate. Nowadays, we do not use magnesium sulfate as tocolysis anymore. So I think to follow an evidence-based guideline, this is one of my favorite websites. It's known as the UK Teratology Information Services. There are two important websites. One is BUMS, known as the best use of medications in pregnancy. And two is to use an evidence-based guidelines, which is available free on site, which is known as the UK Teratology Information Services. That's, for example, Google isoretinoin in pregnancy. Although we do know that oral isoretinoin is associated with an increased risk of miscarriage, fetal cardiac and orofacial abnormalities, based on the UKTIS cohort and registry, topical use is not associated with an increase in adverse effects to the baby. Unfortunately, the patient that I illustrated was only using topical use of isoretinoin that she stopped 4 weeks before embarking on a pregnancy. So by following evidence, by following literature and looking for the right resources, we will be able to safely counsel the mother and provide her with an evidence-based recommendations with regards to medications in pregnancy. And this will be a good resources that almost everyone can use when it comes to medications during pregnancy, not just FDA classifications. Principle number 2, I think we have to appreciate that the fetal risk is not the same throughout the 10 months of pregnancy. It depends on the exposure and also depends on the fetal developmental phase. I think there are 3 phases that we need to appreciate. The first 17 days is known as pre-embryonic phase. And any exposure during the pre-embryonic phase will follow an all or none rule. It's either a miscarriage or a healthy baby. It does not cause any fetal teratogenicity or fetal abnormality. Then comes the embryonic phase, which is between day 18 and day 55. And this is the most important phase where any exposure to any medication could potentially cause fetal structural abnormalities. And after completion of the fetal phase, the risk of causing fetal abnormalities is less. It is usually more of functional. So when you talk about medications, it's important to know when did the exposure take place. Was it pre-embryonic? Was it embryonic? Or was it in the fetal phase? To illustrate this better, ladies and gentlemen, the pre-implantation phase is associated with a higher risk of miscarriage. It does not cause any fetal abnormalities. The first organ that develops is the heart and the brain, and by as early as 11 to 12 weeks, most essential organs would have developed. Hence, exposure in the first trimester is what sometimes is a concern for obstetricians because that may be associated with congenital abnormalities, but exposure after the first trimester, especially after 14 to 16 weeks, usually does not cause structural abnormalities, but it may cause functional defects or minor congenital abnormalities. So it's important to know when in the fetal development phase did the exposure take place. There are also various pregnancy adaptations. There's a reduction in absorption. There's an increase in GI motility. There's a reduction in bowel motility and a GI transit time, which is increased. There's an increase in hepatic flow. There's an increase in GFR. There's an increase in resorption and an increase in clearance. So because of these physiological adaptations, especially the increase in plasma volume, the increase in GFR, a pregnant mother actually needs a higher dose of medications. This can be either a higher dose or a higher frequency as compared to a non-pregnant mother. So ladies and gentlemen, if you compare a pregnant mother than a non-pregnant mother, it is good to adapt this with her physiological adaptations. A pregnant mother usually needs higher doses or more frequent medications. So it goes back to question number 2. A pregnant mother who's on ACE inhibitor, who's got hypertension, when should we discontinue the medications? Although older studies showed that we should discontinue it when she's keen to embark on the pregnancy, some recent studies say that we don't really have to stop the medication pre-conception. But early exposure to ACE inhibitors is not associated with adverse fetal harms, and we can stop ACE inhibitors the moment the urine pregnancy test is confirmed because organogenesis is yet to set in. So not all medications need to be stopped pre-conception. It is okay to ensure that the pregnant mother embarks on a pregnancy as healthy as possible, to educate and empower her, and to stop the medications when the urine pregnancy test is positive. A good example will be the ACE inhibitors. Principle number 3, most effects has got a dose-dependent effect. It's also good to remember the mother's weight because it should not be the same medication for all pregnant mothers. And the current thoughts, essential medications. For example, if you were to start treatment dose of low molecular weight heparin, it should be based on the current dose and not the booking dose because the mother would have gained and changed significant weight throughout the pregnancy. So the current principles and understanding, for example, chemotherapy, for example, treatment dose of pulmonary embolism should be based on the current weight and not the booking weight. But it's also important to appreciate that effect and risk to the baby has got a dose-dependent effects. So I'm going to bring and highlight the importance of pregnancy pharmacokinetics that we spoke about. The pregnancy has got a lot of changes, and that includes the GI transit time, which is increased, lipid and protein solubility of various medications, the increase in plasma volume, the increase in renal excretion, and also some molecular weight of drugs which are heavier in molecule are less transferred as compared to medications that are lighter in molecule. And lipid, plasma solubility, and molecular weight are important considerations during pregnancy as well. I think all of us love our aspirin, and I think we have changed our dose from 100 milligrams, what was 75 milligrams a long time ago, and people now talk about 150 milligrams of aspirin. Now, some people use the booking weight, and they use the simple algorithm of below 40 kilograms, 100 milligrams, above 40 kilograms to use 150 milligrams of aspirin. But I think this dose of aspirin comes from a 1979 paper in the Lancet produced by Mazzotti, who back then showed that by using 2.5 milligrams of aspirin, That is the principle of using baby aspirin. It affects COX-1 and it affects prostacyclin production and platelet aggregation. And that is the only effect of low-dose aspirin is needed. And back then in 1979, we showed that aspirin should be based on the mother's weight. The right dose seems to be 2.5 milligrams of aspirin. I think this highlights the importance of using the maternal weight, that it should not be one same dose for all medications. Mothers who are smaller, mothers who have got less BMI need a separate dose as compared to mothers who are more obese. It's good to precisely dose the mother based on her weight. I think everyone is also well aware by the UK government alert in 2019 with regards to the use of carbimazole. There are two serious considerations back then. First was the use of sodium valproate in pregnancy, especially doses higher than 400 milligrams BD. There was also an alert by the use of carbimazole in pregnancy, especially with regards to doses of above 15 milligrams. So although we are concerned about medications, there is a dose-related effect to the fetus. Not all medications are contraindicated. Sometimes the dose matters. Now, what is the risk of using more than 15 milligrams of carbimazole per day? There's an association with aplasia cutis, craniofacial abnormalities, cloanal atresia, GI abnormalities, and even cardiac abnormalities. So any pregnant mother who's on low dose of medications, there's no need to convert. But any pregnant mother who on high doses of medications, example, carbimazole beyond 15 milligrams a day, is good that she's reviewed in the pre-conception clinic, discuss about the optimization of medications, either to bring it down or either to convert it during pregnancy. But it's important to appreciate the dose-related effect to the fetus, which is very true for certain medications, especially carbimazole and sodium valproate. I believe this important study by the UREP epilepsy trial also highlighted the dose-related effect of sodium valproate. The current consensus is that no woman in the reproductive age group should be on sodium valproate without effective contraception. But this paper showed that there are safer alternatives to pregnant mothers, ideally lamotrigine or even carbamazepine below 400 milligrams as compared to sodium valproate, which is usually not preferred, especially at doses of above 400 milligrams BD, because there's a direct association, a 10% risk of fetal neurological disease, but a 40% risk of long-term neurodevelopmental issues in the baby known as fetal valproate syndrome. So it's important to appreciate the medication, the dose, and also the phase of fetal development. Principle number 4, I think as obstetricians, it's important to know and appreciate pregnancy pharmacokinetics that I highlighted earlier, the molecular weight of the medication, the lipid and protein solubility of the medications, the pregnancy adaptations. So in principle, a pregnant mother needs higher doses, not less, because of the increase in eGFR, because of the increase in plasma volume. And that, I think, is an important principle to consider. Here's an example. Let's talk about steroids. There are many types of steroids, be it hydrocortisone, prednisolone, dexamethasone, and betamethasone. The steroid that has got the best placental transfer is actually dexamethasone and betamethasone. And that is the reason why these are usually given for fetal lung maturity. But if a pregnant mother is on prednisolone, the placental transfer of prednisolone is only 10%. So despite the mother being on prednisolone, for fetal lung maturity, it is also important that she's given a dose of dexamethasone. So it is important as obstetricians to appreciate placental transfer of medications, because not all medications has got a 1-to-1 placental transfer. Certain medications like dexamethasone has got a 50% placental transfer. Certain medications such as hydrocortisone has got a lower placental transfer. It's important to appreciate this and take this into consideration when we talk about prescribing in pregnancy. Certain medications which are large in molecular weight do not go through the placental barrier, and that is also an important consideration. Safe medications that do not go through the placental barrier are unfractionated heparin and low molecular weight heparin. But NOACs, rivaroxaban, dabigatran are usually not recommended, including fondaparinux, because although it has got little placental transfer, it has been found in breast milk, and hence it is usually not preferred in pregnancy. It's also important to take a look at the placental transfer of medications before we decide what is the best option for the mother. Antibiotics. I'm sure there's a high tendency that a pregnant mother may need at least an antibiotic throughout her pregnancy journey, and the Oracle trial back in the late 90s, early 2000s showed the association between augmentin and fetal necrotizing enterocolitis. Although we may argue that that was a study done almost 25 years ago in cohort that had preterm pre-labor rupture of membranes, there were concerns with babies who were exposed to augmentin. Similarly, there has been a single cohort study showing association between macrolides and fetal cardiac diseases. Although these studies are rare, I think when it comes to prescribing, it is often good to discuss with an obstetrician about the safest choice of antibiotics. It should be benefit against the risk. If possible, use the safest antibiotics in pregnancy. Some antibiotics such as clarithromycin has got a better placental transfer, but most penicillins and cephalosporins are the first line of antibiotics during pregnancy. Unless you think this is the best antibiotic for the mother, where the benefit outweighs the risk. But there have been and there are concerns of certain antibiotics usage in pregnancy. And finally, I'm going to talk about anticoagulation. Warfarin seems to be the safest anticoagulant, especially for mothers with prostatic valve disease. And when it comes to warfarin, many people talk about the 5 milligram rule, where people believe doses below 5 milligrams is associated with a 2 to 5% risk of fetal embryopathy as compared to higher doses. But ladies and gentlemen, this is based on a small study published in 1999, almost 26 years ago, who followed the 5 milligram rule. And sadly, various other studies after this did not show an association between dose and warfarin embryopathy. Although dose is important, I think we must counsel patients that warfarin causes fetal embryopathy, which is rare, but there is a 30% risk of fetal loss irrespective of the dose. Now, interestingly, this paper in 1999 only had 28 patients in the healthy fetuses, and out of the 28 patients, 5 babies had complications, and the entire cohort, they only had 31 patients in that cohort. And based on this small sample study, they came up with the 5 milligram rule that many people hold on to today. But having said that, for mothers who have got a prostatic valve, warfarin seems to be the safest anticoagulant for the mother. But I think we should move away from the 5 milligram rule because this is based on a very old study published in 1999. So moving forward, what are the anticoagulation options? Based on this paper, which was published in 2023, the British Society of Hematology now recommends low molecular weight treatment dose 2.5 milligrams per kg per day of low molecular weight heparin. For example, if the pregnant mother is 60 kilograms, it is conventional practice to start her on 60 milligrams BD of enoxaparin, but that is not true for pregnant mothers because the pregnant mother will not require 1 milligram per kg BD, but it's best to start on 2.5 milligram per kg per day which will equate to almost 80 milligrams BD dose of enoxaparin as a starting dose, especially for pregnant mothers with mechanical valves. So it's important to take this into consideration. A pregnant mother usually is more thrombotic. If you're going to start anticoagulation, it should be higher dose, not using the principles similar to a non-pregnant mother. So the current recommendations to start treatment on mechanical valves, anticoagulation, warfarin is the safest for the mother. The 5 milligram rule is ancient and there is a 30% risk of fetal loss. The risk of thrombosis is highest in the first trimester, but the current recommendations is to check peak and trough anti-10A levels. We now live in the era where it's important to check levels during pregnancy because the pregnant mother has got significant physiological adaptations. Examples of medications that needs levels to be checked: warfarin, lamotrigine, and sometimes even tacrolimus, that is important to check levels. And having said that, it's important to check peak and trough anti-10A levels for all mothers with mechanical heart valves on treatment doses of low molecular weight heparin. The recommended dose is that the peak level should be between 1 to 1.4, which is taken 4 hours after the dose, and the trough level should be between above 0.6 for any pregnant mother on treatment doses. And sometimes people add aspirin. But having said that, this is only feasible if facilities are available to check peak and trough anti-10A levels. If facilities are not available, then the next best option of anticoagulation for pregnant mothers with prosthetic heart valves would still be warfarin, although the risk to the fetus is not dose dependent. Spironolactone. Ladies and gentlemen, we appreciated how the placenta acts like a beautiful barrier between the fetus and the mother. And sometimes not all medications are contraindicated. The gender of the fetus also has got implications on safety of medications. Spironolactone, there has been concerns about feminization of the male fetuses. That is true, and although the risk is theoretical, I think it is not contraindicated in female fetuses. So I think although there are concerns about the dose, although there were concerns about the phase, some medications are safe in certain gender of the fetuses. One good example is spironolactone, and there are numerous studies that says the gender of the fetus can now be identified as early as 11 to 12 weeks. It is safe in female fetuses, and any doses of below 200 milligrams per day, irrespective of the gender of the fetus, has got no adverse outcomes to the fetus. So it's important to once again discuss, speak with an expert, make a combined decision, and sometimes working as a team will be able to refine our management of the patients better. We spoke about levels that drop during pregnancy, and the current recommendations, apart from checking anti-10A for warfarin, is also important to check lamotrigine levels. The UREP study showed sodium valproate has got a significant risk to the fetus, and the safer anti-epileptic medications now seems to be lamotrigine and levetiracetam. But lamotrigine binds to the estrogen. The levels drop significantly during pregnancy, and people now believe the levels drop between 40 to 80% during pregnancy as compared to levetiracetam, where the levels may drop between 20 to 40%. So lamotrigine seems to be the safest anti-epileptic for the mother, but during pregnancy, we should either increase the levels prophylactically, but it's even more precise to check for levels. And I think when it comes to precision in medications, checking therapeutic levels, checking for certain medications that are essential seems to be the way forward during pregnancy, because the principle is that a pregnant mother needs higher doses, higher frequency as compared to a non-pregnant mother. And finally, the medications that's given to the mother sometimes stays in the placenta longer. We appreciated the importance of the placental barrier we appreciated the implications of the gender in medications, but certain medications harbor longer in the placenta. A good example is chemotherapy. The recommendations is to stop chemotherapy medications at 34 weeks, ensure there's at least a 3-week washout period before the baby is delivered, because we do not want to deliver the baby being immunocompromised. There's a higher risk of fetal neutropenic sepsis because these medications harbor longer in the placenta. And similarly, the recommendation is to stop warfarin at 36 weeks because although the warfarin in the mother may normalize within 3 days, it stays longer in the placenta and the fetal may be born with a risk of over-warfarinization. So it's important to appreciate placental physiology, how the mother behaves, the medication that goes to the pregnancy, the medication that stays in the placenta is also important considerations. Similarly, we now know that biologics are safe in pregnancy, and there are more and more studies showing the safety of biologics. But it's important to know the half-life of each biologic agent because it's important to determine when is the upper limit to stop these medications. The only concern about biologics is not to the mother, but the concerns about giving these babies live vaccines, especially BCG. Certain biologics such as etanercept, you can stop them at 30 to 32 weeks, but certain biologics such as adalimumab, the recommendation is to stop them earlier. So it's good to check the half-life of these medications. So the options of management of biologics is two. One is to continue the biologics throughout the pregnancy as to render the mother disease-free and stable, but to delay live vaccines in the baby. Or depending on the half-life, to stop the biologics at certain period of gestation with a small possibility of the mother having a flare in the 3rd trimester, but with the benefit that the baby may have live vaccines because there's less concerns with regards to immunosuppression in a baby where the biologics have been stopped beforehand. Principle number 5, although we often talk about medications in the mother, it is also important to take a history about the health of the father, the weight, the age, and also the medications that the father takes. And although we have appreciated that sodium valproate is actually not recommended in pregnancy, a similar dose, a similar medication is also not recommended among fathers who are keen to conceive. There's been numerous studies that showed paternal exposure of sodium valproate is also associated with neurological disorders in the offspring. Although there are recent studies that shows that these concerns are no longer true and valid, it is important to take a history about paternal medications and to counsel the mother appropriately. When it comes to paternal medications, the principles of a 2-sperm cycle is often used, but the medications are usually cleared in 60 days, and that can be one important principle when it comes to pre-conception care. Principle number 6, which I believe is the final principle that I'm going to highlight, having appreciated doses, phases, benefit and risk, I think finally we must involve in responsible prescribing. We should make a shared decision making, and I think the patient should be involved in the decision because often at times it is not because there is harm in the medications, it's purely because there's no research and study that has been done to prove, because pregnant mothers are often not included in clinical trials. A good example, there are more and more pregnant mothers who are on numerous newer medications without safety data. A good example is SGLT2 or pregnant mothers on GLP-1 agonist, which is currently widely used for diabetic patients. Although the evidence is evolving, as obstetricians, rather than saying it is harmful, rather than asking the pregnant mother to stop the medication, it's important to make a shared decision-making and informed consent about the benefits of the medication, about the unknown implications, and allow her to make that decision importantly. And I believe one good example of a shared decision making is the concerns with regards to ondansetron in pregnancy. This JAMA paper in 2018 was one of the earlier papers that showed an association between the first trimester use of ondansetron and fetal cardiac abnormalities. But various other studies after that showed that the risk of an untreated hyperemesis gravidarum was far more significant to the mother where the mother had complications as compared to the extremely rare low risk of ondansetron with fetal cardiac defects. And now we know that ondansetron is safe. We should counsel to the mother, but it is not actually contraindicated in the first trimester if we think that medication is beneficial. So it's important of making a shared decision making and responsible prescribing. One good example, ladies and gentlemen, this seems to be my favorite guideline when it comes to medications in pregnancy. This is free, easily available online. You just need to Google British Society of Rheumatology Guideline for Prescribing in Pregnancy. It tells you various immunosuppressives, various trimesters, including breastfeeding, including paternal exposure, and reassures you, and it's an easy evidence-based tool to counsel patients. I would strongly advise you all to use this guideline in our daily practice. It is not just about immunosuppressive. They also talk about various other medications such as amitriptyline, gabapentin, and NSAIDs, which are actually not contraindicated in any pregnant mother before 30 weeks. So this British Society of Rheumatology Guidelines is a wonderful paper. They've got two guidelines talking about safety of various different medications in various stages, including breastfeeding, including paternal exposure. I would like to spend the next few slides highlighting this new guideline, which came out about the use of psychotropic medications. Some medications does have implications on the pregnancy, and some medications, the pregnancy does have implications on the medications. Antidepressants, there's an association with weight gain. There's an association with preeclampsia. There's an association with GDM. So it's good to know certain medications that may affect the pregnancy. It's good to talk about weight gain, screen for GDM, and absolutely know certain medications that are contraindicated, especially paroxetine, but various other antidepressants are safe. Certain pregnant mothers may have additional side effects such as constipation, dizziness, and urinary retention. So it's good to address these concerns on certain mothers who are taking certain medications. We spoke about mood stabilizers. It's important to check lithium levels as well in pregnancy. Lithium is not absolutely contraindicated. If there's a mechanism to check lithium levels, it's important to check to make sure they are within therapeutic levels. Certain levels such as lamotrigine I've already discussed in the past. We've also discussed and highlighted that sodium valproate is usually not preferred during pregnancy unless that is the one and only medication where we think the benefit outweighs the risk. Antipsychotics, it is best to use the lowest possible dose, and the safest antipsychotic now with the shortest acting seems to be lorazepam, which is now preferred as the first line purely because it is short acting, does not cause any long-term implications as compared to other long-acting antipsychotic medications. So ladies and gentlemen, to summarize my talk, I think it is important to come up with a checklist, and my prescribing checklist. Question number 1, ask what is the benefit of treatment. I think we should appreciate the risk. Is it theoretical? Is it animal studies, or has it really been proven in human studies? I think we should appreciate placental physiology, lipid solubility, the molecular size of the medications. Even more important, it's important to estimate the fetal phase. Has organogenesis complicated? Medications are safe the second and third trimester as compared to the first trimester. Then, is there any alternative options? Can we reduce the dose? Can we use a safer medication? Use the lowest possible dose. If unsure, it is okay to ask a maternal medicine expert, not ChatGPT, not Google, not FDA, but ask an expert. Finally, balance between the benefit against the risk. It's okay to be honest with the patient, but make a shared decision making. To summarize my talk, for allied healthcare professionals, I think the principle number one, do not stigmatize pregnant and breastfeeding mothers. Never stop an important medication without consulting a high-risk expert. That can be warfarin, that can be sodium valproate, because stopping medication sometimes may cause more harm than the medication per se. For obstetricians, I think this is our territory. We should be the obstetric guardian. We should be the expert. We should be knowledgeable with regards to prescribing in pregnancy. We should empower patients and their partners, and we should guide non-obstetricians with regards to safe medications that can be as simple as antibiotics. For physicians, ask the benefit, not always the risk. If it's an important medication that's going to save the mother's life, it should not be withheld. If it's unsure, work as a team, discuss with an expert. But at the end of the day, it's important to treat the pregnant mother the same like a non-pregnant mother, unless there's a strong reason not to. And it's also true for mothers who breastfeed. Do not just ask a mother to stop breastfeeding because the benefits sometimes outweigh the risk. I think for moving forward, often the concerns are with regards to evidence. Often our concerns is not because the medication is harmful, but because there are no evidence with regards to safety in pregnancy. And now the momentum is that every pregnant and breastfeeding mother should be included in clinical trials. And hopefully we'll have better safety data with regards to medications in pregnancy. It's also important to stay updated with regards to the risk of medications, because I believe what is correct and safe today, I think the evidence evolves. One good example is the association of 17-hydroxyprogesterones, which I believe at one time was a commonly used medication, but is no longer recommended, purely because the association with fetal childhood malignancies, doses beyond 3, the use in the first and second trimester. Evidence evolve, medications evolve. It's good to stay updated and watch this space. If unsure, ladies and gentlemen, my favorite websites, BUMS, Best Use of Medications in Pregnancy. It's available free. It will forever be free. You can have information leaflet that you can print and give to your patients. If you've got a patient who's on rare medications, you can Google UK Teratology Information Services. I think Singapore also have got a wonderful HSA that sometimes provides alert with regards to certain medications. But at the end of the day, if it's unsure, it's okay to consult an expert, but please make sure that is the right expert, a maternal medicine expert. With that, I would like to thank you so much for your attention. I'll be more than happy to take some questions.
Thank you very much, Munis, for that fantastic talk. It was really a brilliant whistle-stop tour de force on a difficult but very important topic, and obviously you have clearly put a lot of thought and effort into crafting this well thought out and structured talk. So I believe there are over 400 online. So as a quick reminder to our audience, please do not hesitate to pose your questions to Dr. Munis by writing your question into the Q&A box. Maybe I'll just start off by asking you about lamotrigine, because you did mention the importance of measuring the serum. So in an epileptic patient on lamotrigine, for instance, how often would you be monitoring the medicines? And in Malaysia, what is the turnaround time from the lab? Is it difficult or easy to find a lab, and the cost?
That's a very difficult question, but a very important question, Dr. Lecoq. I think how often to check, it all depends on our resources and our feasibility to check levels. I think in Malaysia, we do not have the laboratory services to check lamotrigine levels, and I actually send it down to Singapore. So in the past, we used to send down to Australia. We had a turnaround time of 2 weeks, which was a bit too long. But now I think we have got important labs that network beautifully. And we can check levels that goes down to Singapore, comes back to us within 4 to 5 working days. When and how often to check? I think it's important to know a baseline level, because that will give us a rough estimate about her level, her clinical symptoms, and the doses. It's important to appreciate that the levels significantly drop during pregnancy. The drop can be between 40 to 80% during pregnancy. So option number 1 is to check the baseline level and then increase the doses based on the level. Or if you think that is extremely challenging or expensive, then it's to increase the levels prophylactically as the pregnancy advances. But the easier, more precise way will be to frequently check the levels during pregnancy. Having said that, the levels drop after delivery, so it's good to go back to a normal levels gradually after delivery.
Thank you. There are a few questions. So the first one, and these are mostly very practical questions. The first one is, can proton pump inhibitors be used in pregnant mothers?
I think we are quite privileged that there is a randomized controlled trial study showing that the safety and efficacy of proton pump inhibitors. So all these medications are safe. They can be pantoprazole, they can be omeprazole, they can be esomeprazole. Interestingly, there is also a study that looked into esomeprazole and prevention of preeclampsia. Although that has not been proven, but proton pump inhibitors have got level 1 evidence to show that it is safe to be used during pregnancy, even throughout the pregnancy.
Thank you. So in other words, it can be used throughout pregnancy irrespective of the trimesters. I think that's very useful information. A second question, I have seen clinicians use Augmentin to treat pneumonia in pregnant mothers. From the reported risk of necrotizing enterocolitis as per the Oracle study, is it not contraindicated to use Augmentin in pregnancy?
I think this is where we need to make a shared decision making. I think any patient who's admitted to the non-obstetric ward or any patient that comes to the ED, I think it's important to have that rapid discussion about safe antibiotics during pregnancy. If we think that antibiotic is extremely essential, there are no other better alternatives, then it is okay to treat and give that mother that antibiotic. But having said that, if there are safer options, then I think it is better to err on the safer side and choose better alternatives. So no medication is absolutely contraindicated, but it's important to weigh balance against risk, to have that discussion and choose the right antibiotic. And I think it's important to work as a team, which I think will make a huge difference.
So on that note, maybe I could ask you about, there was a American Journal of OAG paper on the safety of hydroxychloroquine in pregnancy, and I think the conclusion was that its use in the first trimester is associated with a statistically significant increased risk of fetal abnormality, which of course flies against as maternal medicine looking at physicians or obstetricians looking after patients with SLE, connective heart tissue disease, that they should be on hydroxychloroquine. So what are your thoughts on this, and how would you address queries posed by anxious patients?
Oh, that's an excellent question, Dr. Lecoq. I think we do know the benefits of hydroxychloroquine in terms of prevention of fetal heart block, in terms of mothers who have got SLE. So I think for many years, I'm sure you also use a lot of hydroxychloroquine if it's clinically indicated. Of recent, I think the concerns of hydroxychloroquine was the doses of 400 milligrams. That was a concern in the first trimester. But I believe that paper was important to highlight the association, but did not discuss benefits. But more importantly, they did not look into doses. So I believe at doses of 200 milligrams, correct me if I'm wrong, there's been no studies that showed this fetal risk. and those were usually at doses of 400 milligrams. But having said that, there were not enough scientific papers looking into the mother's indication, associated complications, the mother's weight. So I, for one, use hydroxychloroquine if clinically indicated. The dose that I use is usually 200 milligrams, but it's often based on the mother's weight.
Yes, thank you for that. Another question from the audience with regards the evidence on clopidogrel in pregnancy, and can it be an alternative for patients who are allergic to aspirin or who are not responsive to aspirin?
I think there are two questions here. I think clopidogrel cannot be used as an alternative to aspirin because the pharmacokinetics of how it works is different. Aspirin prevents preeclampsia by inhibiting COX-1, and its mechanism is related to the prostacyclin and thromboxane A2, something that clopidogrel does not do. Clopidogrel is an antiplatelet agent. So I think aspirin cannot be substituted with clopidogrel. When it comes to clopidogrel, there's been enough systematic studies to show that it is safe to be used during pregnancy. The only concern is during labor. So it's safe to be used in the first trimester, second trimester, but the recommendation is to stop it when the mother presents in labor because there's a concern about the mother having a higher risk of hemorrhage. So when is the best time to stop? There's no proper recommendations, but people usually suggest to stop it 7 days before delivery. But it's clinically indicated. I believe it is used for mothers with ischemic heart disease. I think it is not contraindicated in pregnancy.
So let's move to diabetics. I think just now you mentioned the SGLT2 and the GLP-1 agonist. So are these drugs okay in pregnancy besides using metformin?
I think we have to watch this space very closely, Dr. Leacock. But what we know now, mothers who inadvertently use these medications and who got pregnant, there seems to be no increased adverse effects to the babies. I think we can't use it during pregnancy as of now, but if the mother inadvertently gets pregnant, it is okay to continue with that pregnancy, not to say that this pregnancy should be terminated, but she should stop these medications the moment she finds that her urine pregnancy test is positive. Having said that, any mother with any medical complications with important medication should be on effective contraception.
Yes. One question, I think an easy one, can warfarin be used in breastfeeding mothers or only low molecular weight heparin if they have embolism?
So we do know that warfarin does not cross the breastfeeding barrier. It's very safe and it's not contraindicated in breastfeeding mothers.
And I think this one's slightly controversial one. Your thoughts on the recent finding of high-dose folic acid, which we give out almost like sweets, 5 milligrams periconception. We tell all women it's good for their babies. And could this cause cognitive impairment in the offspring?
That's extremely difficult to answer. I think there are two concerns with regards to high dose of folic acid. One, the concerns of fetal cognitive impairment. There are also some concerns about epigenetic theory and fetal malignancies. Although it has never really been proven, I think dose should be given the right amount, not too high, not too low. And only certain cohort of mothers need high doses. Mothers who are on anti-folate medications such as sulfasalazine, or mothers who are on anti-epileptic medications. But most other mothers, they require the usual standard dose of 400 micrograms of folic acid. Yes. It's good to watch this space though.
Yeah. Okay, a very practical question. Cough syrups, cough medicines, are they safe? Cough ones like Prospan, are they safe, or could we safely say that any cough syrup is safe in pregnancy?
Yeah, I think most symptomatic treatment, antihistamines, cough syrup medications are all safe in pregnancy. Although there are no randomized controlled trial studies, I think we do know how this medication works. Although people believe less sedative ones should be the preferred as compared to more sedative ones, but I think it is not contraindicated in pregnancy.
So I think a bit of a philosophical question. medication is prescribing is slowly shifting towards pharmacogenomics, I think is the word. Have you observed its impact in prescribing practices?
I think as the world of obstetric medicine evolves, as we in maternal medicine also evolve, I think the awareness, the knowledge, and the safety of medications we now appreciate better. I think as we progress towards not stigmatizing pregnant mothers, I believe mothers now are getting better medications, the right medications, and the right treatment. A good example will be chemotherapy. Once we thought that it is contraindicated, now we do know that a lot of medications, certain chemotherapy medications are safe. So the correct answer is yes, I think we are on par, although I believe it's important to have more studies, include pregnant mothers in clinical trials, and we'll have better safety data on medications.
A very important question, I think, is just popped up. So you mentioned during your talk that the current weight rather than the booking weight should be used for low molecular weight heparin. Or is this only for postpartum patients?
I think it's more for antenatal patients. For example, if the pregnant mother started her pregnancy weighing 48 kilograms, and throughout the pregnancy she has gained a significant amount of weight and now she weighs 62 kilograms, we should use the current weight. But postpartum, people usually go back to their pre-conception weight because she would have lost the significant amount of water retention during pregnancy. So the current weight for important medications, especially chemotherapy, antibiotics, low molecular weight treatment doses, seems to be the way forward, not postpartum, but antenatally.
So there's a question here. Are we basing our decisions on the assumption that the UPT is taken so early so that it's okay to stop the medicine once she tests positive? How would it affect the decision if the drug is taken and then it's only positive later in the pregnancy? I'm not sure if I'm reading this question correctly. I think the question is about it might be related to what you said about the 17 days, 55 days, and 8 weeks thing when the pregnancy is discovered and she has taken a potentially harmful drug.
Correct. I think there are two schools of thoughts here. Some healthcare professionals advise mothers to take important medications such as warfarin and check the urine pregnancy test every, say, monthly. And the moment it's positive, to stop these medications. Number two, I think the right way to do it, if she's got a complex medical disorder, she's on an essential medication, I think we should prescribe that important medication and also prescribe contraception. So it should not be sodium valproate without contraception. But having said that, if you're not really sure at which stage or which phase the mother is, I'm sure in this era of ultrasound, we can accurately date the pregnancy. And based on that various stages, we can then give her more precise counseling about the risk and harm and the stage of the effect of the drug to the pregnancy. So UPT is the easy way forward, but planning pregnancy, contraception, not gatekeeping, allowing this pregnant mother to come as early to the unit to have her early first trimester dating scan is extremely important.
Yeah, so I think on that note, I will bring this session to a close. I think there are a few other questions coming through, but in the interest of time, I think we'll close the session. I think what I would like to say is that you did mention UKTIS, and I think we had the pleasure of inviting the Director of Service, Dr. Kenneth Hodson, to speak at one of our webinars last year. So just as a heads up, we have invited him and he has accepted to attend our next maternal medicine course in May next year. So in about a year's time. And of course, you will also be invited to this. So I think that will make for a very nice symposium. Right. So thank you very much, Munice. Thank you for spending this last 1 hour with us and for answering all these questions. I think everyone has found it enormously helpful and everyone has learned quite a lot. Thank you.
Thank you so much for inviting.
And to the audience, thank you so much for spending this hour with us and for asking your questions. And just as announcement, our next webinar will be in a month's time on the 1st of July. And this will be the first of 2 talks on thyroid disease in pregnancy that we've lined up for this year. So this next talk will be given by Dr. Poo Tze, who is our consultant in my department. So we look forward to your support and to your attendance next month. So have a good day, everyone. Thank you.